Good morning, and welcome to today's webinar, COVID-19 and Texas Work Injury Programs, Frequently Asked Questions and Answers. I'm Richard Johnson. I am an Executive Vice President with PartnerSource. I have 25 years working with Fortune 500 companies in the design, implementation, and ongoing support of Texas occupational injury benefit programs. I'm also joined today by Dr. Melissa Tonn, who's the president of OccMD.
Good morning, welcome y'all. For those of you who don't know me, OccMD for the past 25 years has been providing evidence-based, outcome-based medical management with a dedicated unit for employers who have injury benefit plans in Texas.
Now, the purpose of today's webinar is to focus on four primary topics: work injury program coverage, work status issues, negligence liability, and then we'll finish with Dr. Tonn talking about medical myths and facts. We have had a lot of questions come up and had issued newsletters over the past 3 months dealing with COVID-19 issues. And at the same time, OccMD has also had several questions that they've been answering with respect to medical issues surrounding this issue. So we want to make sure and try to capture that and talk about some of those today. So let's go ahead and, well, I also want to make the point that we have a tight time frame. So we're scheduled for 30 minutes. So we won't be taking questions during the course of the presentation. However, we will stay online afterwards, and you can submit questions during the presentation. And after it's over, we'll do the best we can to answer some of those questions. I also want to make the note that for purposes of some of the ERISA plan answers that we provide, they're based primarily on PartnerSource design plans. They should be, for the most part, very consistent with other plans in the industry, but as always, you want to make sure and look at your specific plan or insurance policy to see exactly how those terms are defined. So with that, let's go ahead and go to our first question. And the first question is, of course, do Texas injury benefit plans and insurance policies cover COVID-19 claims? And the answer is that in most cases, no. Those plans and policies will generally exclude ordinary diseases of life to which the general public is exposed, circumstances that did not place the employee at a greater risk of harm than the general public, and biological contaminants. Now, the last one, they're typically talking about a biowarfare type situation, but it's definitely important to check with your insurance carrier to see if they're going to cover this type of situation based upon that clause. Now, the key to that is that Texas workers' compensation also excludes COVID-19 for these exact same reasons. So it's very consistent with what's happening on the Texas workers' comp side. Now, with that, of course, the next question would be, are there any exceptions to this rule? And the answer is yes, potentially. There are certain situations where employers have determined that a COVID-19 exposure could be covered under their Texas injury benefit plan. And those situations apply if the employee was placed at a greater risk of exposure than the general public, and if the COVID-19 exposure directly resulted from the employee's work activities. So the perfect example of that I've seen is a nurse who is treating a COVID-19 positive patient. That is her direct job responsibilities to interact with that patient with COVID-19. And she has a higher exposure to that person than someone necessarily in the general public. That might not necessarily apply the same way to someone who is at a front desk in the hospital greeting people who have exposures in many other locations. But so it's a very fact-based analysis. And to that point, that goes to the next question, which is, what are the things that we should look at for purposes of determining coverage? If my situation is one of those exceptions to the rule in a Texas injury benefit plan, well, of course, you're going to look at different factors to see, did the person have a work-related exposure and they were placed at a higher risk of exposure than the general public? So we look at things such as, what are their normal work tasks? Is it their typical job to interact directly with a patient, for example? Were they wearing personal protective equipment? The plan provides benefits on a no-fault basis typically, so if they failed to wear it, that wouldn't necessarily exclude them from coverage. But it's important to look at that to see, did the personal protective equipment actually put them at a lower risk of exposure than persons in the general public. Another important factor is to look at the timing of when the exposure happened. At that time, was there a shelter-in-place order versus did it happen before the shelter-in-place or after as we start reopening the economy? And was that person designated as an essential worker? That will have a key to finding out what is the likelihood that they had multiple other exposures outside of their work tasks. Obviously, we want to look and identify who the exposure source is, look at the timing of that exposure, when it happened, and in some cases, the extent of those exposures. So occupational injury benefit plans will typically cover occupational diseases that don't happen immediately, but may happen over multiple exposures over a course of time. And that's relevant because most plans will have a longer reporting time frame if it's due to an exposure rather than an acute incident that happens at once. You also want to look at the incubation and the quarantine period associated with that exposure. Did the time frame of when that person converted into a positive correlate with the time that they reported that they had their exposures? So you would look at the quarantine period. As you know, it's typically been looked at as either 10 to 14 days before you're going to see symptoms. So that would be important to see that those things tie together. And lastly, very importantly, you'd want to look at and identify with that claimant, were there other non-occupational exposures? Do they have a family member at home that has COVID-19? What are the other places that they go outside of work, hobbies, things of that nature? So for example, I had a claimant that their responsibility was cleaning rooms at an assisted living center, and they were cleaning a room for a positive COVID-19 patient. We went through this analysis, all the dots connected, and that employer made the decision to go ahead and cover that claim. Now, with that said, I'll go ahead and turn this over to Dr. Tonn.
So question, how is COVID-19 being established as related to work? Determining whether a worker has COVID-19 and whether it can be considered a work-related illness requires an analysis of both the clinical diagnosis and work attribution. So CDC has developed a surveillance case definition for probable cases or deaths from COVID-19. And the causation analysis here is the step process of looking at the evidence of disease, meeting the clinical criteria, the epidemiologic evidence, meaning the exposure in the area where the individual worked or resided, presumptive laboratory testing, and then a review of the vital records. So a surveillance case definition by the CDC is intended to cast a wider net about the disease, but is not intended for making a clinical diagnosis. When we look at making a clinical diagnosis, people present typically in 4 different ways. They're either asymptomatic or very mildly symptomatic with cold-like symptoms, may have upper respiratory symptomatology with gastrointestinal symptoms, nausea, vomiting, diarrhea, lower respiratory, meaning pneumonia-like presentation, and then the acute respiratory distress, the fulminant septic kind of presentation with the individuals who have a much worse case of COVID-19. So we look at typical symptoms to make the clinical diagnosis: the shortness of breath, the fever, cough, loss of sense of taste and smell that's new, body aches, nausea, vomiting, diarrhea. Looking at laboratory testing, enzyme elevations, D-dimer elevation indicating possible risk for vein thrombosis. Looking at x-rays with presentation that's often atypical, read as atypical pneumonia, and CT scans showing ground glass opacities in the peripheral lungs. So on the next slide, we talk about testing, and all we hear about is, the testing. So in many cases, people present with the clinical presentation, typical symptoms of COVID-19, and they also have a positive molecular test, the RT-PCR test. But sometimes the diagnosis can be more challenging. They don't have the typical clinical presentation. The problem with the molecular testing is that there's a high percentage of false negatives. So if you have an individual who has a negative molecular result, that does not necessarily exclude them from a diagnosis of COVID-19 if it's clinically strongly suspected. In the case of COVID-19, we have been looking for alternatives to identifying people who have been exposed, who have had the disease, with antibody testing. The problem with the antibody testing is that there's hundreds of tests, and the most recent information is that over 50% of the tests are wrong. So they're not reliable either, which makes this, very difficult if we're relying on diagnostic testing results. So once the clinical diagnosis has been made, the determination of work attribution is important for both determining OSHA reportability and for how the illness will be treated under a workers' compensation or an injury benefit plan. Employers have made the determination across the spectrum from requiring a proven exposure at the workplace to a presumption of exposure if they're typically in the healthcare field. The next slide includes some citations where this data came from. Most is available from the cdc.gov website. I'll turn it back to Richard.
Thank you, Dr. Tonn. Our next topic we'll deal with is work status issues. We've had several questions in this area. So let's look at our first question. And the question is, can a plan pay benefits for COVID-19 testing and quarantine periods? The idea of paying for the initial screening, the testing on the medical side, as well as potential lost wages during the time that someone is quarantined. The answer is yes. Partnership plans have a provision that will talk about initial benefit payments that can be paid during the pendency of a benefit investigation for determining if that person is eligible. It does not preclude the plan if after a 30-day period of investigation, the investigation determines that it is not a work-related COVID-19 exposure. So that's very typical. Just like any other claim, most of our clients will first put forward is care to take care of the employees. Will pay that initial benefit, pay the medical and lost wages until the eligibility decision has been made. You can look at it in terms of you could either classify those payments at that first eligibility period investigation as either ERISA plan benefits, or some employers will choose to treat those as benefit investigation expenses in order to maintain that claim as an incident only in the event that the investigation concludes that it's not a covered benefit claim. Another important thing to point out, though, is that plans will typically not pay for preventive testing. The purpose of the Texas Injury Benefit Plan is to provide benefits once there's been some type of occurrence. So typically that's not covered. Let's look at the next slide. And the next question is, how does COVID-19 affect wages for employees with existing work injuries? Well, in many cases, a PartnerSource plan can pay lost wage benefits if the employee was furloughed while on a work injury leave. Similar, they can also pay if the employee was furloughed while they were working modified duty. And the difference is that in that situation, employers will see that unlike a traditional termination or reduction in force, there's an expectation that that person is going to at some point return to work. So when we've seen folks that have been out on a work injury leave and now there is a furlough across the board, they've allowed those employees in many cases to continue their work injury benefits. At the same time, if the employee is furloughed while on modified duty, there's a different provision in the plans that will typically say that if the employer can no longer accommodate that modified duty position and the employee has not been released to return to work with permanent restrictions, at that point, the person is then again considered to be totally disabled and now eligible again for total disability pay. Now, exception to those rules, if the employee has a reduction in hours. So the employee has been working their full duty, but they're doing it at less hours. And the change that the employer makes is not any type of a termination or furlough, but they just reduce their hours. In most situations, that would not result in the payment of wage replacement benefits or the restart of wage replacement benefits under the plan. Now, it's also important to remember that lost wage benefits combined with other pay should not exceed 100% of the pre-injury pay. So it's very important in these situations that if you are making the decision to pay wage replacement while someone is on furlough, to make sure that you're coordinating those benefits with other benefits they may be applying for, either unemployment compensation or non-occupational disability benefit plans. The work injury benefit plans typically will pay primary over other forms of coverage, including Medicare. However, there are certain types of benefits that they would pay secondary to. So you want to make sure and check with the other side. And for the same reason that if you want to make sure that those other benefits are not paying more and the person is now getting a windfall more than what they would earn if they were normally working at their normal premium. And with that, I'll turn it back over to Dr. Tonn.
So what is the current environment regarding clinical assessments, diagnostics, physical therapy, and IMEs? This is an ever-changing issue and answer to this question. In Texas, the clinics are pretty much fairly back to normal. The staffing has been shuffled. Many of the clinics had closures and had furloughed staff. The surgery centers have established various guidelines for patients in terms of preoperative testing. We're back to doing elective procedures, both diagnostic and surgical. The telemedicine visits are declining in Texas. The tele-rehab visits are declining, but never really caught on. The IMEs were delayed about 2 months. We have IME physicians who have comorbid medical conditions who are concerned and are further delaying their scheduling. But otherwise, we're fairly back to normal. Across the US, major medical centers are reopening slowly, and things are getting back to normal, with the caveat of personal protective equipment and certain distancing and scheduling that is going to be different for a while. The second question in this area is, do we need an IME to assess causation or return to work on a confirmed or presumptive COVID case? I can't really see where an independent medical evaluation would be necessary in a COVID diagnosis or causation or to establish return to work. Looking at the cases we've had, the clinical records would suffice for a medical records review. The next issue on the next slide is returning people to work, and most of our cases have been healthcare providers or healthcare personnel. And the CDC's recommendation for healthcare personnel returning to work is either a test-based strategy or a symptom-based strategy. And the symptom-based strategy requires work exclusion for 10 days from symptom onset and for at least 3 days from clinical recovery. And clinical recovery is defined as an absence of fever without the use of a fever-reducing medicine and improvement in symptoms. Improvement in symptoms does not mean a complete resolution of symptoms. So people may still have a runny nose or a scratchy throat or a little cough. The recommendation is to wear masks when returning to work. You don't have to be symptom-free. The test-based return to work is a little bit more complicated because it requires not only clinical recovery, but 2 consecutive molecular tests that are negative, collected at least 24 hours apart. As I've previously stated, problems with the test, or we have a number of false negatives. We also have individuals who tested negative and positive and negative, further delaying their return to work. A further issue with COVID that is different from other infectious diseases or outbreaks that we've had in the past, which is on the next slide, are unusual circumstances that we're seeing. People who have been off work have become deconditioned. Many have gained weight. They're trying to return to manual material handling jobs, and they're at an increased risk for injury. Individuals who were either furloughed or off work for a period of time or not working a regular schedule have had a change in their circadian rhythms. They complain about a loss of focus and inability to get back in the swing of things and to concentrate. People are scared about the economy and job loss, their vulnerability. They have issues of child care, elder care at home. Physicians are seeing more anxious and depressed individuals as a result of the past couple of months of being in a shelter-in-place situation. And then the most concerning one that's impacting our occupational injuries is pre-existing conditions that over this period of time that haven't been managed. People haven't been going to the doctor for their follow-up visits. Diabetics not getting their prescriptions refilled, people with hypertension not getting their prescriptions filled timely, and then diagnostic delay or diagnosis delay, individuals who have put off getting a cancer diagnosis or some sort of cardiovascular diagnosis has certainly been a problem. I'll turn it back to Richard.
Thank you, Dr. Tonn. Our next topic we'll address is negligence liability. As many of you know, for employers that opt out or make the election not to participate in the Texas workers' compensation system, they lose the exclusive remedy protections of workers' comp. As a result, an employee can bring a negligence liability lawsuit against that employer, arguing that the employer failed to provide a safe workplace, and because of that failure, they were damaged. Now, all of our clients will develop a risk benefit plans that provide benefits on a no-fault basis, that provide great medical care and timely benefits. And as a result, less than 1% of all occupational injury claims in these programs ever result in some type of negligence liability case. However, it's very important when we talk to clients to make sure that when they're conducting their investigations at the outset, they have to be aware of that negligence exposure and investigate that side of the fence as well. Very similar to a general liability claim for a customer. So with that said, we'll look at some of the measures that they should look at in terms of what safety measures that the employer has taken in respect to COVID-19. So again, we want to make sure that those employers are confirming that the safety measures were in place, they were fit for the employee's particular job task, and they followed OSHA and CDC guidelines, very importantly, that were in place at the time of the exposure. As you know, the guidance from CDC has been a moving target, so I've talked to a lot of employers in terms of developing a timeline so that they can demonstrate what was the specific date of the guidance or change in guidance, and how did the employer react in terms of their daily safety practices. Some of the things that we want to make sure and look at from a liability perspective are, were the employees provided with personal protective equipment? Were they using the personal protective equipment? Was it needed for that particular job task? Another area, of course, would be post notice. Did the location have notices on the front of the doors, or those types of notices that you might see for social distancing that are labeled throughout a store? Another example of one is looking at work location adjustments for social distancing rules. For example, I had a client that had a call center and that they had to redesign the entire floor plan of that floor to keep the employees who would normally be right on top of each other in queues properly distanced from each other. They also would look at things in terms of the common areas that they would work with and adjust that so that they were not using common equipment like headphones, things of that nature. You want to gather, like any other occupational injury claim, your safety training documents to show that those employees were trained on how to do their task and they were trained on how that would be affected by COVID-19. And in this particular case, I think it's very important to be able to demonstrate that the employee in question received CDC guidelines, hotlines if they had a question or concern about an employer practice that they were not comfortable with, or web links so that they could gain more information about COVID-19 and how it affects them in the workplace. A very important one is to make sure to check that you conducted management training so that managers knew what to do, and most importantly, that they were enforcing the particular rules that you put in place for COVID-19. The few lawsuits that we started to see popping up around the country have been going down the road of a negligence supervision argument, and the idea that the managers were not enforcing the rules with the customers or with the fellow employees, not enforcing hygiene rules or social distancing. And the other thing to look at too is that did the employer provide accommodations to employees? So if it was a particular employee that was just not comfortable with coming back, were there other telecommunication type options provided or other things that they could do, adjustments to their schedule? That would be very helpful to show that you were acting reasonably. Now, my next question would be, what are the type of things that you should look at once you do have an exposure and need to take corrective action? Well, some of the sample corrective actions that we would be looking for in our investigation were, obviously, was there immediate quarantining if we have a known positive patient for not only that patient, but those that they were directly, those employees that were directly exposed to that person. Similarly, you want to also look at contact tracing, trying to identify as best you can the persons that group were in contact with and what types of common areas they might have shared. So I have had situations where an entire floor, or an entire manufacturing floor, had 2 employees that tested positive, but in certain situations, some of the employees had no contact whatsoever with those people, and the determination was made that they did not have to be quarantined. Similarly, what were the actions that were taken in terms of closing the store or closing the area to allow it to receive deep cleaning or disinfection treatment? You also want to make sure that managers knew what to do when they did get it reported to them in terms of directing the employee for medical and benefit resources. Most employers have been following a standard response for COVID-19 exposures, whether it was occupational or non-occupational, and provided them with a set group of typically non-occupational benefits coupled with some type of special pay for that person during the COVID-19 period. So you want to make sure that the first foot forward was care and the managers knew what to do when they got a report. Again, reinforcing COVID-19 safety measures, showing that the managers were acting reasonably and trying to enforce those measures such as social distancing. And lastly, determining, did management have a prior notice of a potential exposure? That's no different than any other occupational injury claim to determine if there was an occupational hazard in the workplace. Did management have notice and a reasonable opportunity to correct that issue before exposure happened? And then after that, I'll turn it over to Dr. Tonn.
So medical myths and facts. If you look on the internet, you can find a variety of recommendations that are obviously myths. People have been covering themselves in sesame oil, thinking that that's a preventive measure. Eating lots of garlic, which would certainly keep you away from people at least 6 feet, I assume. Taking a bath in bleach has also been thrown out there. More seriously, though, the controversies have surrounded the hydroxychloroquine with or without azithromycin and zinc. And most of the studies and data that are out there are questioning whether or not hydroxychloroquine is a preventive type of drug and if it actually works. The different guidelines have given it a C rating for you can use it in cases of mild to moderate onset of symptoms, not in very ill individuals who are already hospitalized with the addition of azithromycin if you have someone who has more moderate symptoms. The VA study was not a VA study. It was a data search that included mostly very ill hospitalized patients who had no chance of responding to hydroxychloroquine. Costa Rica took an approach to providing their citizens prophylactic hydroxychloroquine with good results so far. They've had a flat rate of case onset. Our experience has been that every individual, most again are in healthcare or long-term care nursing home facilities, and they've been treated with hydroxychloroquine and azithromycin with exceptional outcomes, short-term symptoms, and no evidence that they're going to have long-term sequelae. The use of antivirals, remdesivir is the one that has the most press, has been shown to shorten the duration, especially in hospitalized patients, shorten the duration of ICU stays or keep people out of the ICU and off of ventilators. Convalescent plasma therapy is of significant interest, it has also become a black market item from what I read this morning, and is in clinical trials in different medical centers, again, to shorten the duration of the disease, keep people off of ventilators and out of the ICU. There are clinical trials ongoing with using rheumatoid arthritis drugs. Anti-clotting agents have been added to the mix because a number of individuals diagnosed with COVID-19 have developed deep vein thrombosis, both in their legs and in their arms. UV light has gotten press, everything from people misusing UV light to disinfect their hands. But UV light is a known disinfectant. It's being put in the ductwork of surgery centers and hospitals across the world. It is also in clinical trials to use to decrease the viral load. So with that, I'll send it back to Richard.
Thank you, Dr. Tonn. Well, thank you again very much for joining us today. That ends the presentation portion of our session. However, as I noted, we'll stay online to answer a few questions. I'm looking and I have a couple of questions here that have come up. The first one talks about, does COVID-19 affect any claim filing timeframes? And the answer is yes, in a couple of respects. The Department of Labor has issued guidance indicating that the time period between March 1st and the end of the national pandemic, which was declared on March 1st, is suspended for purposes of determining when a person has to file an appeal. The guidance provides all types of extensions that apply both to timeframes that employees have to file a claim, as well as timeframes that an employer has to provide notice of specific issues, like a COBRA notice, for example. But in our case, for Texas Injury Benefit Plan, the main one is with respect to appeals. So we provided a May newsletter that goes into specifics and examples of how that works, how you count the days. Normally, a person would have 180 days, in most cases, from the date that they received a benefit denial to file their appeal. So for purposes of counting that 180 days, if it's impacted by March 1st, so for example, if it happened after March 1st, that normal time frame would be suspended until the time that the president removes the national emergency declaration. And at that point, they would have a 60-day lag. And after 60 days, then they would still have time to file their appeal. The other one that just was hot off the presses this morning, previously the State Bar of Texas had extended the time frame that plaintiff lawyers could file a negligence liability lawsuit to July 15th. They've now, this morning, extended that again to August 15th. So that's something to be aware of. I've got another question. This was for Dr. Tonn in terms of, are there guidelines other than CDC that employers should follow?
The American College of Occupational Environmental Medicine has a COVID-19 guideline that is available to the public. It is an evidence-based guideline, focuses both on diagnosis and recommended treatments. It has a very well-written section on disability duration for individuals who've actually been diagnosed with COVID-19 and were hospitalized on ventilators, and what the long-term implications are for their return to work, which I think is going to be significant, especially in the healthcare environment. The official disability guidelines also published a guideline, which is a more generic viral pandemic guideline, which should still be available online. If you can't find them, just email me and I'll send them out to you.
And our last question is, can we get a copy of this presentation? And yes, if I believe you provided your email when registering for the webinar, that should be no problem. We'll be able to provide you with a copy. So I don't see any other questions. So again, thank you very much for joining us today.
Thank you. Thank you.